Brenda Wraight is the Director of Health Workforce New Zealand with the Ministry of Health, has been instrumental in the development of the National Health Workforce Plan and workforce development management in general. So it'll be interesting to hear from Brenda, and she is our next speaker. Brenda Wraight, ladies and gentlemen.
Thank you. I think I'm mic'd up and ready to go. Well, thank you for the opportunity to talk to you today. I'm in a group of very esteemed people, I think, who know quite a lot more about mental health and addictions than I do. My background, though, is educational psychology, so I've dipped into some of this in other parts of my working life. Today, though, I want to go through just a little bit of background about Health Workforce New Zealand, some of our programs. I won't go through all of the slides, and I'm really happy that you take the slides away with you, and I can send them through to anyone. Some of them are sort of lists of the activities that we've got underway, provide some context for how we do our work. But I think for the focus for today, though, will be on our work in the area of mental health and addictions, clearly, and most particularly the Workforce Service Review. I think that Ross has indicated that you'd be interested in hearing about. So to start with, Health Workforce New Zealand has been underway for a year or so, year and a half, and our focus is on simplifying and unifying the health workforce development system. That is our overarching priority, really. When we were first established, we did some work on having a look at who was involved in the health workforce development system, and we actually stopped counting at 500 organisations with an interest in health workforce development. And I mean, it astonished us, and so our work over the last year or so has been to consolidate some of those, the activity of some of those organisations, and many will continue with legitimate roles, of course, but many were established for good reason under different governments where there was more money to do a range of things, and were duplicating and not necessarily heading the waka in the same direction. So we have national oversight for health and disability workforce development and planning. Our interest is in a whole of education continuum, whole of health system view. My colleagues over the ditch at Health Workforce Australia have far more money than I do, but also the advantage of having also responsibility for the funding that's in the education system for health. We don't, it's split into different ministries. So our challenge is to create a seamless interaction, a continuum between the health and education systems, particularly around workforce development. And we monitor and respond to national and regional workforce priorities and pressures. Some of this sort of broad oversight role does come out in the Workforce Service Review, and I'll touch on that, but we are very much focused on interprofessional, interdisciplinary, connected workforces and services, and trying to move away from very siloed ways of working. People work in an interprofessional and interdisciplinary way already, and we're not reinventing that. What we are seeking to do is build on that and notice it and observe it where it's working well, and look at what are the principles that underpin it and build on those. We've got a number of innovation projects underway, and in a range of areas, including in mental health and addictions. One of those is strengthening up the nursing workforce to better respond to people with mental health and addiction needs in primary care particularly. We partner with people, though. Although we're the central agency for workforce development, we don't have the answers. You do, the sector does, and the way in which we work is to facilitate, enable and partner with you to get the things that you need to be progressed. And one of our other major priorities is to make sense of all of the data that comes and that is collected in the health system. We're drowning in it, but there's very little intelligence applied to it, really. Everyone collects data, but none of it really talks to each other. The systems don't connect, and now we're building a nationally accessible workforce data set, which, starting with the regulated workforce, because that's where data is collected, but the bigger challenge is around the unregulated workforce, and we really don't know how big that workforce is, where it is, what it's doing. Parts of the sector know what its part of the sector does, but we, as in Health Workforce New Zealand, need a better understanding of that. Broadly, these are our overarching objectives: recruitment and retention, a workforce with more generic skills. And I was reading this morning, in fact, a press release from one of our health sector unions on the need to recruit more specialists and pay more and all of those things that do come through at this time of year when the sort of industrial things are being bargained for. But we can't, New Zealand's a small country, a small and relatively poor country. We can't continue to get increasingly more specialised. We do need a workforce that has a range of skills so that the workforce is more easily deployed, more easily trained. You can add on to what you know with advanced competency modules rather than having to go back to the beginning to retrain. We're very interested in new roles and extensions of existing roles, so that the workforce is working to the top of its scope wherever it is in the workforce system. As I mentioned before, I'm interested in strengthening the workforce relationships across the health and education systems, but also across the health and education and justice systems. And I've just been talking to Bronwyn about her role in justice. And one of the ways that we're trying to unbundle, I suppose, some of those boundaries between those systems is to attack it at every level, and I mean it in a nice way. So minister to minister, having conversations there, chair to chair, CE to CE, and staff to staff, so that at every part of the system they're talking and so heading in the same direction together, but you do need to work at every different level to make a difference. And of course ensuring high quality, integrated and best value training wherever that training is occurring. So at the highly specialist end through to the unregulated self-care, home care, community care end. We've achieved most of our short-term targets over the time since we've been established. We've noticed a shift in workforce culture. Improved morale, engagement, and those people I've been talking to over the last several weeks the comments they've made to me is that we've noticed a groundswell. People kind of get it, that we need to do things differently, the status quo is untenable, all of those things, they get it, and people are working under the radar sometimes, but certainly I'm noticing quite a change certainly since we were first established. We've worked hard on future-proofing our planning process and developing up a prioritisation criteria so that the funding that we invest into the workforce system has absolute rigour around the decisions that we make around it, so that it's not just here's a bundle of money and we'll make it add up to 10. So that every worker that we provide funding for, there's a rationale behind why it's that person or why it's that area of work and not another one. And recasting the primary care workforce, I hear people say that shifting care into the primary sector, care is already being provided in the primary sector, it's not a new phenomenon, but strengthening up that workforce, so all of those people who work in primary care, to respond to people with, in your area of work, mental health and addiction needs, but also across the whole system. We can't just kind of shift care out of hospitals into GPs without doing something else, so we're working quite hard in that space. For 2011-12 and beyond, these are our priorities. Again, bringing services closer to home, community and home care, the carer workforce and self-care. And we have a project underway at the moment looking at some of the incentives and rewards really for particularly around community and home care, the carer workforce and self-care. What does it take for people to take more responsibility for their own care, but to be supported to take that responsibility, for people to have some skin in the game? There do need to be some incentives there. Increasing the number of Māori and Pacific in the health and disability workforce, and working closely with colleagues in Māori and Pacific workforce development there to think about how best to do that. Is it about setting targets? We'll have this many in this area. What exactly is it? Is it about strengthening the whole system, strengthening the pathways into the health workforce, keeping people in the health workforce while they're there and supporting and retaining them? It's all of those things. I mentioned strengthening the workforce in primary care. Workers working to the top of their scope. It's the sort of the cheapest, most competent health worker. And a more visible and tangible education and health sector continuum, so that we can move, if you're in the health workforce, wherever you are, if it's within self-care, and I do consider people, that is part of the health workforce, that you can easily duck in and out of workforce development. It's not difficult, that it's accessible, it's visible, and you can go back and revisit things, you can add on, you can move around flexibly in the system. And the three priority areas that we have on our radar for next year and the foreseeable few years are aged care, mental health and addictions, and rehabilitation. Many of you will know that we embarked on a series of workforce service reviews. These are generally clinician-led reviews of a particular service area. Some have been about a particular specialty area. It depends on where they started. The purpose is to propose a 2020 vision for the health workforce, but thinking about what's the health system need, what are the population health needs into 2020 and beyond, where will those needs be met, so what services will be provided and where, and then thinking about what's the workforce that we need to meet those needs. The parameters we put around the reviews were no more money. Essentially, we can't expect any more money to come into the system. A doubling of demand, no loss of access or quality, patient and person-centred, very much keeping the person at the centre of this, interprofessional and interdisciplinary, and thinking about public-private and, in fact, I should say NGO sector in there. So we're not just thinking about publicly delivered services. Those are the reviews that have reported to date. We have 2 underway that will report in probably October, Women and Babies Health and Rehabilitation, and then one starting on the cancer workforce and service shortly, and oral health, but in the oral health one particularly focusing on reducing the disparities for Māori and Pacific people in oral health. So the reviews, the processes the reviews have configured themselves really in terms of the membership of the review teams. We've asked the people leading them to think about the most strategic and innovative bravest thinkers in their area, convene that group as a think tank. It's not intended to be the definitive answer to all things, in this case mental health and addictions. It's a small group coming together to think about the issues that they're looking at. And that's the first phase, and so we've received the reports of those reviews and we're working through the recommendations. Some of the reviews have 20 recommendations, some 4, vastly different focus for each of the reviews, and we're now working through those and thinking about who else should be involved, broadening out the membership of that group, or the people who need to be involved in that phase, and thinking about, well, what are the gaps, what have we missed, what have we simply got, what's the review simply got wrong, what are the priority areas that we should focus on out of the reviews. But over all of them, although they're all very different, 4 key themes have emerged from them universally. So making better use of the existing workforce, from untrained through to specialist, developing new roles and extending roles. So those were things we'd thought in Health Workforce New Zealand were important. They've been reflected now in the reviews as some of the themes that have been coming through. A focus very much on prevention, rehabilitation and self-care, underpinning a shift in resources from hospital through to community. Better use of the potential of IT, including telemedicine, and development of regional clinical networks, managed clinical networks, so not necessarily a bunch of same clinicians meeting, but a clinical network that integrates clinicians and workers in the health system across that system. We'll be putting, and it might even be later today, the Mental Health and Addictions Workforce Service Review up on our website, which has what I'm going to summarise here in it. So if you don't need to take notes, and also make these slides available to you. The recommendations of that review propose, and this won't be new to you, I have to say that none of the reviews have proposed stuff that's rocket science. It's all stuff that you're doing, but they do put it together in one place and highlight areas to, not only to us, but to government, to ministers and the sector, as these are the things we really need to focus on. So certainly a shift in the focus of mental health service towards primary and integrated care and preventive interventions at both ends of the life cycle. And I know Lynn, when in her presentation she introduced the life cycle model, thinking about the whole continuum of care and the continuum of life from beginning to end. A whole of system person-centred view, again keeping the person at the centre of thinking. Family and whānau-centred approaches to self-care and positive wellbeing. The intention and the goal is to reach the 7 to 9% of the population who have the highest mental health and addiction needs, but also create a supportive environment for the wider population and improve access to those with unmet mental health and addiction needs. And I mentioned before one of the initiatives that we've got underway with the College of Mental Health Nurses on strengthening up the nursing workforce working in primary care to better respond to people who are in the particularly presenting in general practice who have unmet mental health needs. And I'm sorry, there is lots of writing on here, and but it's necessary. There's so much depth in this review, and my understanding, and Lynn will nod if this is right, that the review in fact underpins the blueprint, the new blueprint. And I'll, as I said, I'll make these available, but intervening earlier in the life course, so not kind of continuing to intervene at points, but thinking about life course and intervening much earlier. And all of these will have resource implications and workforce implications. Integration across primary, secondary, working with other agencies, child, youth and family, education and justice to reduce the system-wide costs. And thinking about the pathways where there is increased risk of mental health and addiction issues, care and protection and justice services. Proactively managing the mental health care for the elderly, and the burgeoning demands on the health and health system around our ageing population are just something that it's looming large. I mean, it's here and looming large, and constantly, pretty much on a daily basis, I'll have a conversation with a part of the sector, a workforce part of the sector, who have a conundrum that they haven't faced before, and one of the ones was in the dietetic workforce. And around aged care, one of the most challenging problems is malnutrition around the older person's population. And it's not something you think about, but those are the things that it's a very complex area, and unmet mental people who are not feeling well mentally will exacerbate some of those other things. And you're all familiar with this. But we also, as well as moving care and supporting primary care to better respond to people with mental health and addiction needs, it's not to say we still don't need to invest in the specialist end of things as well, and we absolutely have to make a focus on that. Part of our prioritisation criteria work that we've been doing is looking at which areas of the medical workforce in this instance are most vulnerable and critical, and one of those areas is psychiatry, and thinking about that'll be where we invest heavily to support the psychiatry workforce. We really struggle to get the number of psychiatrists into the system, but it's not just that, it's looking at psychologists and the capacity that exists in the psychologists workforce to respond. Again, I'm really sorry about all of the material in here. It is lengthy, but important. And I think one of the salient points is that we do need a workforce that can respond to a 7-fold increase by 2020, and a 7-fold increase in response levels to people with mental health and addiction needs. And functioning as part of an integrated team. And I'll leave you to read through that. So, and I will skim through these next slides, but as I said, they are available, and it's just going back to our overarching objective. So when we've got the Workforce Service Review has come in, we've looked at it, we're thinking about what the most important things are that we need to drive forward on. We'll go back to our overarching objectives and overpinning that, really, overarching that, simplifying and unifying the health workforce system. And within all of these, I mean, these are just, I won't go through them in detail, but the number of initiatives and activities that we've got underway in each of our priority areas. One of the areas that we are working on at the moment, linked to this one, is reforming GP training so that we have a general practice workforce who can work across settings, primary, community, and developing up advanced competency modules with the general practice workforce. And the first one that we're developing up is around mental health and addictions. There's some of the innovations underway. strengthening relationships across the education and health systems, and I talked before about our need to meet at every level of the system rather than try and kind of beaver away at one place. Our role, Health Workforce New Zealand's role, is to work at every level of the system, and we've been doing that with the Tertiary Education Commission, for example. We're also interested, traditionally the funding that that I inherited as part of this role was the CTA funding, and that had been targeted on postgraduate clinical training. Our interest is in, you can't just prop things up at that end. You have to look further back, and you have to be, we have to be involved at the undergraduate and with the unregulated workforce, with career force. So we're having all of those conversations so that it's a seamless education system. And the last couple of slides are around the way in which we're sort of, configuring the health workforce system so that we can do what we need to do. And one of them is establishing 4 regional training hubs. And the regions are the DHB geographic regions. They are underway now, or 2 of them are underway, and the other 2 will be underway by the end of the year. But that again is to coordinate activity rather than duplicate across 20 district health boards the same sort of stuff. Try and integrate that, trying to get best value for money for our trainees, but get a much stronger health workforce development system that responds better to the needs that are being identified. And we will require from January 2012 career plans for every trainee that we fund, and the reason behind that is severalfold. Good pastoral care is underpinned by that. Mentoring is incredibly important to retaining our workforce. And we're not being prescriptive about what those career plans look like. What we're saying is a conversation needs to have happened between you, trainee, and somebody more senior to you who can assist you to navigate through your career at any point in your career. So again, looking at career planning for older and retiring clinicians in the workforce, because you know we tend to sort of disregard clinicians who are at the end of their working life as not necessarily needing to continue to relook at what might I need to do next, what interests might I have in putting back into the health system. And the other interest is that we do want to assist people to navigating towards the areas that we most need our workforce to be working in. So having conversations that are informed by the priorities that our health system are glaring at us. And I think this is my last slide, sort of examples of what I'm seeing as a tangible health and education sector continuum, and I want it. I picture it in my head. I haven't quite drawn the diagram yet, but it is it's pipeline into the system. It's retaining people there, enabling people to duck in and out of it as they wish, come in and out of the system, be supported and have access to really good, high quality training at whatever part of the workforce they work in. And that's my last slide. So thank you. I'm happy to be part of the next part of questions.
Thank you, Brenda.